Hi, welcome to Unacademy. Let's crack NEET PG. I am Dr. Shilpa Dinesh. I'm a practicing pediatric consultant and an educator in Unacademy. I have an experience of teaching undergraduate and postgraduate medical students, and I've done my MBBS and MD from Rajiv Gandhi University of Health Science. So today we are going to have a big quiz. I mean, around 75 MCQs are there for discussion. So basically, this is the continuation of the previous MCQ discussion. Okay. So the remaining blood disorders we are going to discuss today. Fine. So before that, I would want to talk a little bit about Unacademy. Unacademy is India's largest online learning platform. There are a lot of benefits you can avail from this platform. Firstly, the daily live classes. Okay, so there are various educators in this platform having various regular classes. You can attend your favorite educator's class, engage in discussions, ask your doubts, and these doubts will be immediately answered in the live chat box. Next, coming to the structured course. So whenever you're preparing for your entrance exam, you need to have a structured approach. You need to plan really well. So by the time you give your entrance exam, you would have revised very well. So here in Unacademy, all our courses are structured in line with your exam syllabus, and this is going to be a huge boost for your preparation. Next, coming to the live tests and quizzes. So whenever you're preparing for your exams, you have to evaluate yourself. You need to know what are your strong areas, what are your weak areas. Only then you can concentrate on those topics which you are not so strong at. This is only possible if you attend as many tests and quizzes as possible. Okay, so here in Unacademy, there are regular tests and quizzes happening, and this will help you to analyze your performance better. Okay, next coming to the unlimited access. So once you subscribe to the subscription, you get access to all the classes that are exclusive to the subscription platform. Okay, so even if you have missed a live class, you can go back and watch the recorded classes again and again, and all this in the comfort of your home, in the comfort of your own device. So I highly recommend this platform, and using this platform in the beginning part of your preparation will take you a long way. These are the top educators in the platform, and they have regular classes happening in the YouTube as well as in the Unacademy platforms. You can attend their classes as well. Okay, so the 19 subjects required for your NEET PG preparation are taught in this platform. And also, if you go to the Unacademy app, you can see that there are various courses like the foundation course, the batch course, the crash course. So you will get access to all, because there will be a very concise class of the entire subject. So you can go and attend these classes as well. So coming to the NEET PG subscription package. So as you can see, the NEET PG subscription package varies from 1 month to 2 years. Okay, so I would highly suggest the 1 year or the 2 year subscription. That is because that becomes very economical, especially for students who are in their third year, in their final year, or in their internship. For them, the 1 year or the 2 year subscription is very economical. Okay, and the students who are giving their NEET PG 2021, for them the 6-month subscription should be good enough. Okay, so the 6-month subscription will cost you 20,000, and using my code Shilpa 10, you get a 10% discount, and it will come up to 18,000. The 12-month subscription 25,000, and using my code Shilpa 10, you get a 10% discount, and it will come up to 22,500. And the 2-year subscription is 30,000, and using my code Shilpa 10, you get a 10% discount, come up to 27,000. Okay, so the rates are very reasonable and it's very economical, and using this as early as possible, I mean starting your preparation early will take you a long way. And see, basically in the third year and all that, so to concentrate on your entrance exam becomes difficult. So such videos, will help you to revise faster, and you can start making notes from right now itself. So by the time you give your exams, you will be very well revised. Okay, so now today's topic, we'll come to today's topic. Okay, so first of all, first question. So I'll be giving you all 30 seconds for every question. Okay, so I'll put a timer on. Okay, so we'll start now. 1 second. So megaloblastic anemia may be caused by all of the following except. So is it phenytoin, methotrexate, pyrimethamine, or amoxicillin? So write down in the comment section. So we will have a discussion on the topics. So what is the answer? So which drug doesn't cause megaloblastic anemia out of the following? Yes, very good, Ganesh. So answer is amoxicillin. So amoxicillin does not cause megaloblastic anemia. So phenytoin causes folic acid deficiency. So these are the drugs which can cause megaloblastic anemia. So very good, Tejas and Sumitra. Fine. Next, so deficiency is intrinsic factor of Castle causes. Deficiency of intrinsic factor of Castle causes microcytic anemia, pernicious anemia, Cooley's anemia, or the aplastic anemia. Yeah, hi, good afternoon, Tejas. Hmm. Yes, Aparna, the answer is for very good. All of you all have come. I'm very happy you have come to the class. So today it's going to be a long class. Let's see. It will be between 1.5 hours to 2 hours. So let's see how long we'll continue going through it. I hope you all have had your lunch already. Okay, so tell me, so deficiency of intrinsic factor? Yes, very good. So all of you all are right. So it causes pernicious anemia. So fine, tell me what is Cooley's anemia? So what is Cooley's anemia? What is Cooley's anemia? Okay, so yeah, tell me what is Cooley's anemia? Yes, beta thalassemia major. Yes, nursing blocks, high beta thalassemia major. Yes, very good. So beta thalassemia major is Cooley's anemia. Fine. Next, a patient has HB of 6%, folic acid of 8, vitamin B12 of 60, serum iron is 160 and MCV is 104. What is the diagnosis? Is it iron deficiency anemia? Is it vitamin B12 deficiency? Is it folic acid deficiency or pyridoxine? What is the deficiency? Okay. Yes, correct, Ganesh. So the answer is vitamin B12. So as you can see, the MCV is raised and the folic acid is very low. Okay, but the iron is normal, but the hemoglobin is low. So the answer is vitamin B12 deficiency. Okay, vitamin B12 deficiency is the answer. Fine. Do not get confused with folic acid. So the answer is vitamin B12. Okay. A 9-month-old boy presented to you with complaints of progressive lethargy, irritability, and pallor since 6 months of age. Examination revealed there is severe pallor. Investigation showed hemoglobin of 3.3, 3.8. MCV was 58, MCH was 19.4. Blood film shows osmotic fragility being normal. Okay, X-ray skull shows expansion of erythroid. So I think I've discussed this. Forget it, we'll discuss this. Leave it. Next question. A patient presents with macroglossia and loss of tongue papillae. His HB is 11.5 and MCV is 100. What should be the next step in investigating this patient? Is it vitamin B12 deficiency, or you should get a brush biopsy of the lesion? Is it fluconazole treatment, or is incisional biopsy? So tell me, what is the next evaluation in this patient? Yes, very good. So it is vitamin B12 deficiency. So you can see there is macroglossia, there is loss of tongue papilla. So this is a picture of vitamin B12 deficiency. So you have to keep in mind, and also you can see that the MCV is on the higher side. So that should give you a clue that this should be a megaloblastic anemia or a macrocytic anemia. So mostly this tongue involvement is seen in vitamin B12 deficiency. Okay, so next. Which of the following changes in the tongue are seen in pernicious anemia? Is it atrophic glossitis or molars glossitis, sore tongue, or all of the above? So tell me, which of the changes are seen in the following? So the I will have you answer. I will answering. Yeah, wait. See, it is seen in all of the above. So the in pernicious anemia, all are seen. So sore tongue is there. Okay, especially in vitamin B12 deficiency, they have pain. Okay, there is sore tongue. Atrophic glossitis is there. So I've told you already. There is the tongue papilla and all are retrophitic. Molar glossitis is nothing but a superficial glossitis. I mean the superficial involvement of the tongue. So over here what happens, there is reddish patch of the tongue and there is increased sensitivity to hot and spicy food. Okay, so this is a superficial glossitis and there is increased sensitivity to hot and spicy food. So we get such kind of patients. Okay, so this you should know, molar glossitis. Fine. Next, true about the blood finding in pernicious anemia. MCH is high, MCHC is high, MCH is high, MCHC is normal, MCHC low, MCH low, MCHC high, MCH low, MCHC normal. So tell me what is the finding in pernicious anemia. So tell me. So MCH, so you should know MCH is what in these patients. I have already taught pediatrics. Okay, so the answer is MCH is high. So basic MCH is high. So the concentration of hemoglobin in the cells is normal. Okay, the MCH is high. MCH cells are big. There is hemoglobin is there, but the concentration of the hemoglobin is normal. So MCH. Okay, so MCH is high. MCHC is normal. So remember that, Aparna. So such small things we have to keep in mind, where the MCV, where the MCHC, and where the MCH is differing. So you will get a clinical scenario like this, and that is how you all should. It looks confusing, but if you will have a keen eye on the parameters, you will be able to answer it. Okay. And for the nursing blocks, I have taught the theory for all these classes. Okay. So this is a question after all the theory I am doing right now. Next, which of the following electrolyte imbalance can occur in the treatment of pernicious anemia? So is it hypokalemia, hyperkalemia, hypocalcemia or hypercalcemia? So tell me, which is the electrolyte imbalance that occurs in the treatment of pernicious anemia? What is the electrolyte imbalance? Think and answer. Don't suddenly jump. Wait, you have enough time. Think and answer. Okay, so there is hypokalemia. There is hypokalemia. So remember, there is hypokalemia in these patients. Okay, so there is sudden change in the electrolysis, hypokalemia. So remember, the answer is hypokalemia. So I'm sure Aparna knew the answer, but then I think you just got confused. The answer is hypokalemia. So in pernicious anemia, the electrolyte during the treatment of the treatment, the electrolyte imbalance which occurs is the hypokalemia. So remember that it's hypokalemia. Fine. Next question. Megaloblastic anemia due to folic acid deficiency is commonly due to, is it inadequate dietary intake, defective intestinal absorption, is it absence of folic acid binding protein in serum, or is it absence of glutamic acid in the intestine? This is very easy, should be able to answer. Megaloblastic anemia due to folic acid deficiency, the most common cause. What is the most common cause? Yes, so it is because of the inadequate dietary intake. So in always, such deficiencies first always think it should be inadequate dietary intake. If that option is not then you have to think, you have to break your head where it could be. So most of these deficiencies, the first thing you have to keep in mind is inadequate dietary intake. So the answer is inadequate dietary intake. Fine. Folate deficiency occurs most likely in which of the following conditions? Folate deficiency. Right now we are talking about folate deficiency. So folate deficiency occurs most likely in which of the following condition? Is it pernicious anemia? Is it celiac disease? Is it ulcerative colitis? Or is it ileocecal tuberculosis? Is it ileocecal tuberculosis? Folate deficiency occurs in most likely occurs in which of the following condition? Yes, I'm talking about folate deficiency. Do not confuse yourself. Talking about folate. Yes, it is celiac disease. So basically there is no absorption of happening. So it is celiac disease. Pernicious anemia is vitamin B12. Okay, so even ulcerative colitis, there is vitamin B12. Ileocecal tuberculosis, there is vitamin B12 absorption is affected. The answer is celiac disease. Okay, so do not confuse yourself. The answer is celiac disease. Fine. Thiamine deficiency is known to occur in all of the following except food faddist, homocystinemia, chronic alcoholic, chronic heart failure patient on diuretics. Okay, so thiamine deficiency. So the question was this, so I've added here. So tell me. Yes, so very good. So the answer is homocystinemia. Homocystinemia. Okay, so here thiamine deficiency is secondary to that. For homocystinemia is the answer. Food faddism and chronic alcoholic is very commonly known to cause thiamine deficiency. Also in this patient's chronic heart failure, but homocystinemia over here there is no thiamine deficiency. So remember that. So the answer is Simon. So Tejas, very good. So you've answered the answer. Next, all of the following causes aplastic anemia except all of the following causes aplastic anemia except. See, I'm just doing the answer and question because most of the discussion has been done. Because there are 75 questions. If I don't do the questions, then again we'll lag behind. So only if topics which I have not discussed, I will discuss. Fine. So now tell me all of the following diseases, all of the following cause aplastic anemia except paroxysmal nocturnal hemoglobinuria, hepatitis, pregnancy, or cold hemoglobinuria. So tell me which condition doesn't cause. Okay, so the answer is the answer is cold hemoglobinuria. So paroxysmal nocturnal hemoglobinuria presents with pancytopenia, hepatitis, especially in conditions like what is it? CMV hepatitis, Epstein-Barr hepatitis, they will present with pancytopenia. Pregnancy has a temporary pancytopenia. So basically hemoglobin comes down, platelets can come to the lower level. So there is a temporary pancytopenia and therefore it is not seen in cold hemoglobinuria. So this is a trick question and this had come in the AIMS 2015. Okay, so this is answer is cold hemoglobinuria. Right? So just it's okay, don't feel bad. Just see the questions, keep in mind. So again, you can, once I finish the class, you can again go back and watch the slides. So there's no problem about it. Okay, next, a patient with hemoglobin of 6, total count of 2000, has a normal differential count except for having 6% blast. Okay, so there is a normal differential count, but they have 6% blast. Platelets are reduced to 80,000 and there is moderate splenomegaly. What is the possible diagnosis in this condition? Is it leukemia? Is it aplastic anemia? Is it hemolysis, or is it ITP? There is hemoglobin of 6, total count of 2000, differential is normal, but there is blast cells. This is very simple. You should be able to answer this. Yes, very good, Ganesh and Parna. The answer is leukemia. Okay. So first of all, there is pancytopenia. Okay. Then there is splenomegaly. So first thing is presence of splenomegaly is not there in aplastic anemia. So that is gone. So leukemia, presence of blast cells are only in the leukemia out of all these options. So answer is leukemia. Very good. True about aplastic anemia are all except splenomegaly, reticulocytopenia, thrombocytopenia, neutropenia. What is true about aplastic anemia out of one is false? What is false? Yes, very good. So in aplastic anemia, you do not see splenomegaly. So that is the right answer. Very good. Fine. So regarding Fanconi anemia, what is the wrong statement? Okay, so right now we're talking about Fanconi anemia. So what is the wrong statement in the following? Autosomal dominant, bone marrow shows atrophy, usually normocytic macrocytic anemia, all of the above. Okay, tell me the best option over here. So this is the latest question, and somewhere around 2015 this question had come with the same options, but give the best option available here. Regarding Fanconi anemia, what is the wrong statement? Yes, very good. So the answer is autosomal dominant. Okay, so this over here they've written all of the above. So do not. So that is why even when such questions come, you have to see the options. Suddenly, don't jump. So the answer is autosomal dominant because Fanconi anemia is autosomal recessive. Fine. So the answer is autosomal dominant. Fine. All are true regarding Fanconi anemia. All are true regarding anemia of chronic disease except serum iron is decreased, ferritin is decreased, decreased total iron binding capacity, and increased bone marrow iron. So the iron. So which is false over here? Yes, very good, Ganesh. The answer is decreased ferritin. Decreased ferritin. Okay. So the ferritin should be increased in anemia of chronic disease. So basically in the bone marrow and all there is sufficient iron. But only in the serum you don't see the iron enough. So the serum iron is decreased, but the ferritin is increased. While in iron deficiency, and so ferric pills have a iron deficiency anemia and anemia of chronic disease. When you get serum iron and then if you get serum ferritin, you should know serum iron is decreased in both, but ferritin is decreased in iron deficiency anemia and it is increased in anemia of chronic disease. So you have to know that. So very good, Ganesh and Tejas. So answer is decreased ferritin. Fine. Now, seen in a chronic inflammatory anemia is serum iron is decreased, serum ferritin is increased, or so just check, see the option. So tell me which is the best option out of this. So in basically anemia, so chronic inflammatory anemia is nothing but anemia of chronic disease. So tell me, what is the best option available here? Aparna, previous question I had told something. What was the previous question? Yes, so very good. So over here what happens is, what happens? The answer is 1. So first of all, you have to see only two options have increased ferritin. Okay, so either it should be 1 or 2. Okay, when it comes to the serum iron is decreased. So over here serum iron is increased. So again the second option is gone. So it is serum iron decrease, serum ferritin increase, and transferrin saturation decrease. So transferrin saturation is decreased because the iron is not enough to bind to it. Yes, very good, Tejas. So remember, the ferritin is increased. So that is a confusing thing. So in iron deficiency anemia and iron anemia of chronic disease, you have to know that iron is decreased in both. That is serum iron, but ferritin is decrease in iron deficiency and increase in anemia of chronic disease. So keep that in mind. So such small things only we do end up doing mistakes, to have a keen eye on that small things. So these things you should make short notes, so that it will help you in revision fast, because what happens is you might forget. So today you'll remember, after 2 months you'll forget. So that is why you need to have a short notes where you can just turn around, and whenever you're free just go through it, and it will help you to refresh your memory. Fine. Next, a patient presents with microcytic hypochromic anemia, serum iron levels and the total iron binding is decreased. Likely diagnosis is. Okay, total iron binding capacity, okay, is decreased. So likely diagnosis is. Don't confuse. Total iron binding capacity is increased in anemia, iron deficiency anemia. Total iron binding capacity is increased in iron deficiency anemia, right? Over here, total iron binding capacity is decreased. Yes, yes. So it is anemia of chronic disease. These are very small. So I will tell you. So again, see, I have this entire 1 more week. Okay, I'll be discussing about blood disorder. So we'll do it again and again. So I'll give you all different. Whenever I start any new class, I will give you all these scenarios again and again, so that you all remember. Okay. So remember, total iron binding capacity is decreased. So in iron deficiency anemia, total iron binding capacity is increased. Fine. So this is anemia of chronic disease. So these are the questions from the past exams. It's not nothing I have done on my own, because there are so many questions that I could just use the old questions. Whenever see, I'll be doing questions in this entire 1 week. I will have more and more questions, so that you all don't get confused. So these are all small things. Though you all know the theory, but when the question comes, you might suddenly get overwhelmed. It'll be like so much, what could it be, kind of a thing. So don't worry, we will have in this entire 1 week, I will have questions on all these topics again and again. It might be boring for you all, but it will help you all to remember better. Okay, next, a 50-year-old patient with rheumatoid arthritis presented with HB of 6, MCV of 60, serum ferritin of 200, serum iron 30, total iron binding capacity of 280. What is the diagnosis? Is it iron deficiency anemia? Is it anemia of chronic disease? Is it thalassemia, or is it autoimmune hemolytic anemia? Okay, so you'll answer, right? So the answer is anemia of chronic disease. So now what? Tell me. So the total iron binding capacity is 280. Okay, so but the normal range is between 250 to 450. So it comes under the normal range. So normal or decreased, you should think. Okay, so normal or decreased. So that is why, first of all, another thing clue is over here there is rheumatoid arthritis. Okay, and the iron is low. Iron is decreased. So what is the normal range? So that normal range is between 60 to 150. So the normal range is 60 to 150. So iron is decreased. Total iron binding capacity is normal. So in chronic anemia of chronic disease, it would be normal to decrease, but it is never increased. Okay, so this gives you a clue of anemia of chronic disease. Fine. Next. True about anemia of chronic disease are all except HB level is usually in the range of 4 to 6 gram %. Increased serum ferritin, total iron binding capacity is low or normal, transferrin saturation is reduced or normal. So what is falls out of this? No, yes, the answer is 1. Okay, so generally in an anemia of chronic disease, the anemia is mild. Okay, so this is a definition for severe anemia. So in case of anemia of chronic disease, it is mild. Total iron binding capacity is low or normal. Transferrin saturation is reduced or is normal, because it is reduced because iron is decreased. Okay, that is why it could be transferrin saturation is reduced, but it is reduced or normal. So this is a feature of iron deficiency anemia. But so that is why, remember, the false is hemoglobin range of 4 to 6. So generally it is a mild anemia in anemia of chronic disease. Okay, so remember, I think Aparna is getting confused with these terms. So we'll do once again: iron deficiency anemia, anemia of chronic disease. Chronic disease. Okay, so now you should know 3 things over here. So one is the serum iron, ferritin, total iron binding capacity, and the transferrin saturation. Okay, so in iron deficiency anemia and in anemia of chronic disease, the serum iron is decreased. Okay, so ferritin, what happens? The ferritin is, see, the basically ferritin is a value which reflects the tissue iron stores. So basically the tissue iron stores are not affected here. Okay, so the ferritin is decreased. So in iron deficiency anemia, the tissue stores are also decreased, while in the anemia of chronic disease it is not. So ferritin is increased. So total iron binding capacity is decreased, is increased in iron deficiency anemia. Over here it is decreased or normal. Okay, or decreased or normal. It is not affecting the iron binding capacity because the tissue stores are still normal. Transferrin saturation is normal, even here it is normal. Okay, so both the sides, transferrin saturation is normal or reduced. So more of or reduced. So generally here in iron deficiency, the transferrin saturation is decreased. So keep that in mind. There are few things. The main thing is the ferritin and the total iron binding capacity. Okay, fine. So now tell me, what is the formula for transferrin saturation? Is it serum iron by total iron binding capacity into 100? Or is it total iron binding capacity by serum iron into 100? Or total iron binding capacity by serum iron, or serum iron by total iron binding capacity? So what is the transferrin saturation? So transferrin saturation is basically the receptor, the saturation of the receptor, so basically binding of the iron to this transferrin. So if it is low, what happens? The iron is low, then the transferrin saturation is low. If it is normal iron, it is normal. Yes. So correct, Ganesh. The answer is serum iron by total iron binding capacity into 100. Okay, so that gives you the clue. So if the serum iron is decreased, then the iron binding capacity is increased, right? So that gives you a clue of the transferrin saturation. So serum iron by the total iron binding capacity into 100. Fine. Next. All of the following are features of hemolytic anemia except decreased RBC lifespan, decreased haptoglobin, unconjugated hyperbilirubinemia, bilirubin in urine, and altered erythroid and myeloid ratio. So tell me which of the following is not there. So we are talking about hemolytic anemia. There is hemolysis. Sugar is tell me. To see the question, so only once you'll answer, I will tell what is it. So erythroid and myeloid ratio is altered. See the thing is, there is no, the answer is there is no bilirubin in the urine. The erythroid and myeloid ratio is altered obviously because see there is so much hemolysis happening. It's not affecting the myeloid cells. Okay, so the erythroid cells are getting affected, and therefore the ratio of the erythroid and the myeloid cells are altered. Okay, so not here in this case the myeloid is not affected, only the erythroid cells are affected. So there is RBCs are damaged, and there is more increase in the RBCs, and therefore the erythroid and the myeloid ratio is altered. So the answer is bilirubin in the urine. Okay, so bilirubin in the urine is the answer. So when you see a pink stain, okay, in the urine, there is a chance of having pink stain in the urine or hematuria. So if there is hematuria, what does that mean? If there is hematuria, what does that mean? In a child with hemolytic anemia, there is hematuria. So what? Hemoglobin. Yes, exactly, Aparna. There is increased erythrocyte turnover, and that is by the there is altered erythroid and myeloid ratio. So now tell me, if there is pink stain in the urine, that is hemoglobinuria. Nuria. So what does that indicate? What does that indicate? So that I've already told you all in the class on hemolytic anemia. So what does that mean? So that means there is intravascular hemolysis. So one of the indication, okay. So if it's hemolytic anemia, there is a presence of blood in the urine, then it is it is because of intravascular hemolysis. Hemolysis, not glomerulonephritis, is because of intravascular hemolysis. So I have told you all in the class what happens basically, because there is so much cells, so much RBCs produced in a hemolytic anemia. All these RBCs go and bind to the haptoglobin. So now there is no enough haptoglobins for the RBCs which are produced to bind. So as a result, what happens? These RBCs are they will be in the plasma. So the plasma, when you see the plasma instead of the buffy coat, they have a pinkish color. So that is another cause, and also there will be hemoglobinuria because all this excess RBCs will be seen in the blood, in the urine. So that is the reason of intravascular hemolysis. Fine. Next. All are features of hemolytic anemia except thrombocytopenia, hemosideruria, decreased haptoglobin, or raised indirect bilirubin. So what is the feature of what is falls out of this? Yes, so very good, Tejas and Ganesh. The answer is thrombocytopenia. So the thing hemosideruria is basically that is the RBCs which break and pass in the urine. So again, this is a feature of intravascular hemolysis. Hemosidenuria is a feature of intravascular hemolysis. So basically I was talking, no, decreased haptoglobin, not the answer. Decrease, basically see, uh, in hemolytic anemia, so generally what happens, there is increased RBC production because of the increased hemolysis. There is increased production, erythrocyte production from the bone marrow. So there is so much increase in the RBCs. So generally once the RBCs come out to the blood, they bind to haptoglobin. So now there is only limited amount of haptoglobin in the body. So what happens that all these are saturated, even in spite of so much RBCs being. So that is why there is no enough haptoglobin to bind. So therefore, the decreased haptoglobin is a feature of hemolytic anemia. Okay. So here thrombocytopenia is not a feature. So that is the answer. Next, haptoglobin levels are decreased in G6PD deficiency, paroxysmal nocturnal hemoglobinuria, a mismatched transfusion reaction, or all of the above. Haptoglobin. So haptoglobin is a protein which is a transport protein which binds to the RBC. Okay. Haptoglobin is decreased in all of the following. In which of the following? What? Yes, very good. So all of the above. So basically, all these three above conditions are features, are causes of hemolytic anemia. So even if there is a transfusion reaction, there is hemolysis happening. So that is why haptoglobin levels are decreased. Okay, in all of the conditions. So anywhere hemolysis is there, there is increased RBC production. Haptoglobin will get decreased. Fine, or levels are decreased. Basically, it is not reflected when you get a haptoglobin level. It is not reflected because that is all saturated by the erythrocytes. Fine. All of the following cause intravascular hemolysis except, is it mismatched blood transfusion, is it snake bite, is it thalassemia, or paroxysmal nocturnal hemoglobin? Yeah, so tell me which doesn't cause intravascular hemolysis. No, the answer is thalassemia. Okay, so the answer is thalassemia. So basically over here, there is no there is extravascular hemolysis happening. Over here, these abnormal RBCs are destroyed in the spleen. Okay, so that is why there is splenomegaly. Okay, so this is the cause of extravascular hemolysis. Tell me other causes of extravascular hemolysis. I have discussed in my previous class. So tell me other causes of extravascular hemolysis. So most of the hemolytic anemias are extravascular. There are only few intravascular hemolysis. So now tell me what are the extravascular hemolysis? Tell me some of the causes you all should know. Okay, so one is the main thing you should know is hereditary spherocytosis, because over here there is abnormal cell and that gets hereditary spherocytosis. Yes, very good. Next, other causes. Tell me in enzyme defects, out of pyruvate kinase deficiency and G6PD, out of these two, which is which causes extravascular hemolysis? Yes, sickle cell anemia is extravascular. So tell me out of pyruvate kinase and G6PD deficiency, which causes extravascular hemolysis? Out of the two, which causes hemolysis? I've told you all in the class. Yes, pyruvate kinase. Very good. So pyruvate kinase deficiency causes extravascular while G6PD causes intravascular. Okay. So intravascular, you should know G6 D and PNH. Rest most of the conditions go for extravascular hemolysis. But they say in sickle cell anemia, two-thirds of the chances of going into um, extravascular and one-third chance of going to intravascular. So since two-thirds is a bigger number, we'll take sickle cell anemia for extravascular hemolysis. Okay. Yes, pyruvate kinase deficiency. Yes, and yes, in pyruvate kinase there is rigid. The cells become rigid, and that is why there is extravascular hemolysis happening. So very good. Next question. So remember in intravascular G6PD deficiency and PNH. Okay, so these two you keep in mind. So the rest, most of it is so other conditions like all this snake bite. Okay, so all these toxins, they can cause intravascular hemolysis. Right. Next, reticulocytosis is seen in all except paroxysmal nocturnal hemoglobinuria, hemolysis, nutritional anemia, or thalassemia. Reticulocytosis is seen in all except reticulocytosis is seen in all except paroxysmal nocturnal hemoglobin. A. Reticulocytosis. Don't confuse. See the question. Reticulocytosis. Retic count. Okay. We'll tell where. Very good. That is why don't jump. Just see properly. Very simple question this is. So reticulocytosis is a feature of hemolysis. Right? So hemolysis. So it should be nutritional anemia. Where will there be hemolysis in nutritional anemia? Right. So the answer is nutritional anemia here. Paroxysmal nocturnal hemoglobinuria is a hemolytic disease. The hemolysis, there is hemolysis happening, so retic count should increase. So there is blood loss and all, there is increase in retic count. Thalassemia is a hemolytic anemia. There will be increase in retic count. So reticulocytosis. Okay, don't confuse. I don't want you to be calm and see. Don't worry. So this is not an exam. This is just a discussion happening. Aram se you'll answer. Don't worry. Fine. So even if you'll even if you all have not been able to answer this, you can again go back and watch the entire video again. So aram se I'm waiting for your answer. I'm not in a hurry. Okay. Fine. Now, warm or autoimmune hemolytic anemia may be seen in all of the following conditions except SLE, alpha methyl dopa, non-Hodgkin's lymphoma, and mycoplasma pneumonia. So tell me, warm autoimmune hemolytic anemia is seen in which condition? Very good. So the answer is mycoplasma pneumonia. Okay, so over here what happens, there is cold agglutinin, there is a reaction called as cold agglutinin immunological reaction happening. So there is not warm autoimmune hemolytic anemia, instead it is a cold autoimmune hemolytic anemia happening. So mycoplasma, so this you should remember, that is one of the complication of mycoplasma infection. So in my class on mycoplasma pneumonia, I have discussed about this as well. So what are the complication of mycoplasma pneumonia? So right, Ganesh and Tejas, the answer is mycoplasma pneumonia. Over here there is no warm autoimmune hemolytic anemia, instead it is cold autoimmune hemolytic anemia which is happening. Okay, so do not confuse, it is cold. So this is one of the, so there are various infections which can cause this cold autoimmune hemolytic anemia, and that one of the infection is the mycoplasma pneumonia. Very good, both of you. Next, cold hemolysis is associated with, cold hemolysis is associated with, I think it is associated with IgM, IgD, IgA, and Donat-Landsteiner. So Donat-Landsteiner antibody, Donat-Landsteiner antibody. So tell me, Yes. So the answer is IgM. Yes. So the cold hemolysis, cold antibodies are seen with it is IgM mediated. Okay. And warm antibody is mediated by warm antibody is what? Is what? This is pediatrics only. This is pediatrics only. So basically, you think these don't happen in pediatrics? Yes, IgG. So IgG. Okay, so the warm antibody is IgG. Fine. Next, autoimmune hemolytic anemia is seen in sickle cell anemia, chronic lymphoblastic leukemia, acute myeloid leukemia, and multiple myeloma. So tell me, autoimmune hemolytic anemia is seen in. If there is autoimmune hemolytic anemia and all, you think it won't be seen in children? Okay. So, tell me. So it is seen in CLL. Okay, so don't confuse. It is in the chronic lymphoblastic leukemia. Autoimmune. So I'm talking about autoimmune. Okay, autoimmune. So basically, autoimmune is what? There is a reaction in the body with the antigen antibody reaction happening. So that kind of a reaction is seen in CLL. Okay, so do not confuse. In sickle cell anemia, basically sickle cell anemia occurs why? Because there is a mutation in the gene. So we'll discuss about that in the next slide. Okay, so the answer is CLL. Okay, so now if there is autoimmune hemolytic anemia, which lineage of cells are affected, can have malignancy? So a patient with autoimmune hemolytic anemia is associated with malignancy of which lineage of cells? Is it T cell, B cell, pre-B cell or pre-T cell? See, I'm trying to put all the questions what have come in the past. Okay, so that it could be patho or it could be pediatrics. Only yes, very good, Ganesh. The answer is B cell. So, in autoimmune hemolytic anemia, there is a chance of going in for B cell malignancies are high. Very good. B. It is answer is B, not pre-B. Don't confuse. So, answer is B cell. Fine. This we finished. Okay. Now, Coombs positive hemolytic anemia is seen in all except Coombs positive. So, again, to tell in autoimmune hemolytic anemia, the generally Coombs test will become positive. So, Coombs positive hemolytic anemia is seen in all except alcoholic cirrhosis, chronic active hepatitis, primary biliary cirrhosis, or primary sclerosing cholangitis. Yes, yes, very good, very good. So the answer is alcoholic cirrhosis. Over here, there is there is uh, no reason for a Coombs test to be positive. So it is a alcoholic cirrhosis. It's purely because of alcohol. So it is alcoholic cirrhosis. Fine. Now, low serum haptoglobin in hemolysis is masked by is masked. One second, let me see. Is masked by pregnancy, liver disease, burns, and malnutrition. So in such condition, even though there is hemolysis, it is not seen. Low serum haptoglobin in hemolysis. So in these conditions, which can cause hemolysis? Which condition can cause hemolysis? Low serum haptoglobin is in hemolysis is masked by in which condition? So basically only one condition there is hemolysis happening. Okay, and then maybe another condition. Yes, very good, Aparna. So the answer is burns. Okay, so in this condition, so though there is hemolysis, you will not be able to get a low serum haptoglobin. So in liver disease hemolysis, there could be low haptoglobin, but in burns, though there is hemolysis, the low haptoglobin is low levels of haptoglobin is marked or is masked. Okay, it's not seen. Basically, what happens, there is no increase in the RBCs also. Though there is hemolysis happening, there is no so much increase in the RBCs when there is burns happening. So they might not be able to see the low serum haptoglobin. Okay, fine. Causes of inherited hemolysis are all except inherited. Paroxysmal nocturnal hemoglobinuria, sickle cell anemia, thalassemia or G6PD deficiency. Inherited hemolysis. So tell me, all these you should know what is the inheritance, which doesn't have an inheritance in the out of these four. Yes, the answer is paroxysmal nocturnal hemoglobinuria. So it becomes easy. Fine. Next, hemolysis most likely occurring in which of the following individuals? Hemolysis most likely occurs in which of the following individuals? Weavers, farmers, army soldiers, or carpenter. Hemolysis is most likely in which individuals? Is seen in which of the following individuals? Weavers, farmers, army soldiers, or carpenter. Yes, very good, Ganesh. The answer is army march. So basically, these people, army soldiers will have a long marching happening, and in these patients there will be hemoglobinuria. Okay, there is hemoglobinuria in this. There is long march in these patients. These have, it is also called as a march syndrome. So the answer is army soldiers. Okay, so the army soldiers. So that you should keep in mind. Okay. So there is hemoglobinuria in these patients. Fine. It's also called as March hemoglobinuria. So in these people there is what they call as March hemoglobinuria. Okay. Fine. Spur cell anemia is seen in alcoholic liver disease, chronic renal failure, vitamin B6 deficiency, or Fanconi anemia. Spur. Spur cell. No, not chronic renal failure. Why chronic renal failure? Why chronic renal failure? Yes, so the answer is alcoholic liver disease. Okay, so the answer is alcoholic liver disease. I don't know why this question I put over here. Okay, anyway, so alcoholic liver disease. Spur cell anemia is a feature of alcoholic liver disease. Spur cell. Okay, spur cell. Spur cell anemia is a feature of alcohol. I know, sorry, I am very sorry. This is a medicine question. That is why you all got confused. Okay, so remember alcoholic liver disease. Okay, it is, so I have put this question, I just put it over here, so you all are getting confused because you're checking for pediatric options. So so that is why I'm saying when we do pediatric we'll only think about pediatric. So this is one the question where I have given. So spur cell anemia is a feature of alcoholic liver disease. So they have anemia, there is spur cells over here seen. Okay, so it is a feature of alcoholic. I know you all got confused because you all are thinking purely pediatrics. Okay, so that is why it will, a bias like this will happen. So that is why always, it's always best for you all whenever you are preparing for entrance exam to study this grand test where all the questions of all the subjects will be there. So that time what happens, this bias will be ruled out. So at least once a week try to do grand tests including all the subjects. Okay, so at least 100 questions per day at least you all do. So that time this bias will go. So what happens when you are doing only pediatric or only pathology questions, that time you all will think the question will be only related to that subject. Okay, so I'm very sorry, but I feel this is okay. Good, I put this question so that now I know how you all think. So always in a week, one test at least you should do a grand test. Okay, that will help you to by the time you give your exam, it will help you to clear your mind very well. Okay, fine. Next, the following protein defects can cause hereditary spherocytosis, except, okay, ankyrin, pallidin, glycophorin C, or band 3. The following protein defects can cause hereditary spherocytosis, except, yes, very good. Ganesh, the answer is glycophorin. So all the three, rest of the three are the defects which cause hereditary spherocytosis. So the answer is glycophorin C. Fine. Next, features of hereditary spherocytosis include all of the following. There is except increased osmotic fragility, increased MCHC, increased MCV, decreased surface area per unit volume. So what are the features? Increased osmotic fragility, increased MCSC, increased MCV, decreased surface area per unit. Yes, very good. So the answer is increased MCV. Very good. So very good. The answer is increased MCV. So increased MCV is not seen in hereditary spherocytosis. Fine. Osmotic fragility is increased in. So you all know this question. Is it sickle cell anemia, thalassemia, hereditary spherocytosis, or chronic lead poisoning? Osmotic fragility. Yes. So answer is hereditary spherocytosis. Very good. This is very simple. Okay. Aplastic anemia and hereditary spherocytosis is precipitated by, is it parvovirus, HIV, adenovirus, influenza virus, or measles virus? Simple this is. These are all very simple. Tell me. Yes, parvovirus is the answer. This is the best. Yes, both are all are right. Splenectomy is most useful in. So basically, splenectomy is most useful in thrombocytopenia, HSP, hereditary spherocytosis, or sickle cell anemia. Splenectomy. Splenectomy is most useful in. Yeah. So answer is hereditary spherocytosis. So tell me what happens in sickle cell anemia. In sickle cell anemia, what happens to the spleen? In sickle cell anemia, what happens to the spleen? Yes, there is autosplenectomy happening. Okay. So autosplenectomy happening. Fine. Next question. A stem cell disorder affecting all three cell line platelets, RBCs and leukocytes is hemolytic anemia, paroxysmal cold hemoglobinuria, paroxysmal nocturnal hemoglobinuria or Blackfan-Diamond syndrome. A stem cell disorder affecting all the three cell line, that is the platelets, RBC and leukocytosis. Is it hemolytic anemia or is it paroxysmal cold hemoglobinuria? Is it paroxysmal nocturnal hemoglobinuria or is it Blackfan-Diamond syndrome? This you all know. Yes. So paroxysmal nocturnal hemoglobinuria. So this affects the myeloid progenitor cells. Okay, so that is why this is a stem cell disorder. So paroxysmal nocturnal hemoglobinuria is a stem cell disorder. So tell me, what is Blackfan-Diamond syndrome? Blackfan-Diamond syndrome? Yes, correct. Very good, Aparna and Ganesh. And tell me, what is Blackfan-Diamond syndrome? Yes. What is Blackfan-Diamond syndrome? Yes, it is a pure red aplasia. So over here you don't see thrombocytopenia or leukopenia. So generally it is more of a red RBCs being decreased. Sometimes in 20% of these cases there could be thrombocytopenia, but in here it is more of a decrease in the RBCs. Okay, pure red cell aplasia. Fine, aplasia. PNH is associated with, okay, that is associated with, tell me, PNH, paroxysmal nocturnal hemoglobinuria is associated with. Yes, very good. All of the above. Okay. So basically what is DAF? It is the decay accelerating factor. Decay accelerating factor. This is the glycophosphoinositol. Phosphoinositol. This is very important for the anchoring protein of the protein which is required to anchor the cytoskeleton. So glycophosphoinositol. What is middle? That is the membrane inhibitor of reactive lysis. So all these are associated with PNH. So the answer is all of the above. So very important is the decay accelerating factor and the glycophosphoinositol. So middle rib, keep in mind. Okay. Fine. Chronic hemolysis from which condition may be associated with iron deficiency? Is it PNH, thalassemia, hereditary spherocytosis or G6PD deficiency? Chronic hemolysis can lead to iron deficiency anemia in which of this condition? Chronic hemolysis can go for iron deficiency anemia. In which condition is that? Yes, Sage is correct. Your guess is right. It is paroxysmal nocturnal hemoglobinuria. So thalassemia, first thing, is never associated with iron deficiency. It is iron overload. And in G6PD and hereditary spherocytosis, there is no association with iron deficiency. In fact, there is in paroxysmal nocturnal hemoglobinuria because there is more of the bleed which is going as blood loss with the in the urine. Okay, and there is no enough heme for the there is no enough heme to bind to the iron. So that is why paroxysmal nocturnal hemoglobinuria can go for iron deficiency anemia. Fine. Okay. Which of the following is not seen in PNH? That is paroxysmal nocturnal hemoglobinuria. Which of the following is not seen? Is it thrombosis or hemosideruria, decreased LDH, or is it thrombocytopenia? So what is not seen? Yes, the answer is decreased LDH. So, all thrombosis is seen. Hemosideruria is basically the heme in the urine. Okay, so hemosideruria is there. Then there is thrombocytopenia. There is pancytopenia. So the answer is yes, loss of hemoglobin in the urine. Correct. So the answer is decrease. There is thrombosis. That is one very common complication of paroxysmal nocturnal hemoglobinuria. Thrombosis is there. Okay. Don't confuse. Thrombosis is the feature. They'll have stroke-like features in paroxysmal nocturnal hemoglobinuria. There is hemosideruria. There is thrombocytopenia. So the answer is decrease. So that is out. There is no this thing only connection only. They've simply put there. There is decreased LDH is not there. Okay. Fine. Now, hand test is based upon. So I know Aparna will answer this. Hand test is based upon the glycophosphoinositol anchor proteins, acidic medium, spectrin protein, or the mannose binding protein. Ham test. So I remember Aparna had told about the ham test in the PNH class. Yes, very good. The answer is acidic medium. So basically, the patients with paroxysmal nocturnal hemoglobinuria, they have an acidic blood, and acid result that is taken for the as a test for. So correct. The answer is acidic medium. Okay. So the answer is acidic medium. Don't why you confuse why confusion now, Ganesh? So you've answered it right. So answer is acidic medium. Okay, fine. All of the following are true about paroxysmal nocturnal hemoglobinuria except. Yes, sucrose lysis test. Okay. So now tell me, all of the following are true about paroxysmal nocturnal hemoglobinuria except. No. So the answer is hypocellular marrow. So basically they have a normoblastic marrow. Okay. There is hyperplasia. Okay. There is hyperplasia in the marrow. So one thing you should know about hypocellular, so causes of hypocellular marrow, this I'll discuss some other time. I don't have the list. I have to make a list for this, so I will only tell half of them. Then the hypercellular marrow or the cellular marrow. Okay, so you should know the causes of this, because as I've seen the questions, there are many questions based on this hypercellular marrow. Okay, so that we have to. So this is not aplastic anemia. So in aplastic anemia kind of a picture, there will be a hypoplastic marrow. Okay, but again, not all aplastic anemia will have hypoplastic marrow. So we here there is there is hyperplasia happening, and as a result there is no hypocellular marrow. So the answer is hypocellular marrow is false. Okay, so you have to make some a sheet or chart of hypocellular marrow and hypercellular marrow. So tomorrow before starting the class we'll discuss about that. Okay, hypocellular and hypercellular marrow. Fine. All of the following can be associated with paroxysmal nocturnal hemoglobinuria except. All of the following can be associated with. I will tell you of each and every this thing now. The options I'll discuss about each and every option. Yeah, so correct. Massive splenomegaly is the answer. So basically, I all know there is thrombosis. Okay, so cerebral thrombosis occurs. So in Budd-Chiari syndrome, what happens? There is thrombosis in the hepatic vein. Thrombosis in the hepatic vein. So this feature of the patient basically has thrombosis happening, and this thrombus happens in the hepatic vein. So that is why Budd-Chiari syndrome. Okay, thrombosis in the hepatic vein. Okay, and also they will have pancytopenia. So the answer is massive splenomegaly is not there in paroxysmal nocturnal hemoglobinuria. So fine. Next, paroxysmal nocturnal hemoglobinuria is associated with all of the following except aplastic anemia, increased uh, leukocyte alkaline phosphatase score, venous thrombosis, and iron deficiency anemia. Do for this is not this just scratch the score. Okay, increased leukocyte alkaline phosphatase. Yes, very good. So the answer is increased leukocyte alanine transferase. Okay, alkaline transferase. So that is the answer. That is not the leukocyte alkaline phosphatase is not increased in paroxysmal nocturnal hemoglobinuria. So there are various questions which have come based on this. So the answer is leukocyte alkaline phosphatase. Fine. Next. Features of paroxysmal nocturnal hemoglobinuria are all except there is thrombosis, pancytopenia, splenomegaly. It is a pre-malignant condition. Feature of paroxysmal nocturnal hemoglobinuria are all except. So what is false? Yes, the answer is splenomegaly. Fine. Next question. Okay. Which of the following is the gold standard to diagnose a case of a paroxysmal nocturnal hemoglobinuria? So we have discussed even this. So tell me, ham test or sucrose lysine test or flow cytometry or bone marrow. Which is the gold standard for the diagnosis of paroxysmal nocturnal hemoglobinuria? We've discussed this. Yes, it is 3-flow cytometry. So flow cytometry is the gold standard for the diagnosis of paroxysmal nocturnal hemoglobinuria. Fine. Next. Causes of hypercellular marrow with pancytopenia are hypercellular. So they've told about hypercellular marrow with pancytopenia are paroxysmal nocturnal hemoglobinuria, myelodysplasia, paraneoplastic syndrome, or are all of the above. Hypercellular marrow. What are the causes? Yes, all of the above. Ganesh, all these causes hypercellularity. Okay, so the answer is all of the above. So again, see, that is why there are so many questions. Even I was reading through, there are a lot of questions on the marrow. So we'll have a discussion tomorrow. Fine, hypercellular, hypocellular, cellular. So we'll have a discussion on the various different types of marrows. Okay, so the answer is all of the above. All of these conditions causes hypercellular marrow. Okay, all the conditions. So basically, there is increased production, no? So that is why all these conditions cause. Most common cause of death in paroxysmal nocturnal hemoglobinuria. So most common cause of death. Is it venous thrombosis, infection, bleeding, or none of the above? Venous thrombosis, infection, bleeding, or none of the above? This is very simple. You know this. Yes, very good. So answer is venous thrombosis. Fine. Yeah, venous thrombosis. So that is the most common cause of death in these patients. Fine. Next, treatment for paroxysmal nocturnal hemoglobinuria. So what is the drug which is used? So is it eculizumab, infliximab, rituximab or alintuzumab? So which is the drug which is used? So you'll have answered me, is it? Tell me what is the drug for paroxysmal nocturnal? No. So the answer is, I have told this in the class. The answer is eculizumab. Eculizumab was a drug. It is a monoclonal antibody. So I think you got confused with rituximab. Even that is a monoclonal antibody, right? So here eculizumab is used. Eculizumab. Remember, in paroxysmal nocturnal hemoglobinuria, it is eculizumab. We have discussed in the class. So other than the hematopoietic stem cell transplant, the drug which is used, very important, you should remember this drug I had told in the class. It is eculizumab for paroxysmal nocturnal hemoglobinuria. Okay, fine. Now, next question. The mother has sickle cell disease, father is normal. Chances of having a sickle cell disease and a sickle cell trait respectively are. So, the mother has sickle cell disease and the father is normal. What are the chances that the child can have sickle cell disease and the sickle cell trait? So first you should know what is the difference between sickle cell disease and sickle cell trait. So basically sickle cell trait is a carrier while sickle cell disease has a homozygous condition. So what is the chances if the mother has a sickle cell disease and the father is normal? What is the chances of inheritance of sickle cell disease and sickle cell trait in a child? Yes, very good. So if one of the parent is only having a sickle cell disease and the other parent is normal, the child only becomes a carrier or has a trait, will have a trait. But the sickle cell disease is not, won't happen because you need two genes to affect the child. Okay, so it is autosomal recessive and it should be a homozygous state to have the disease. So correct, both of you are right. So it is a 0 chance of to develop sickle cell disease while it's a 100% chance to have a sickle cell trait. Fine. Next. The primary defect which leads to sickle cell anemia is, what is the defect in sickle cell anemia? Is it an abnormality in porphyrin part of the hemoglobin? Is it replacement of glutamine with valine in the beta globin chain, or is it a nonsense mutation in the beta globin chain, or is it a substitution of valine by glutamine in the alpha globin chain? So tell me, what is the primary defect? Yes, very good, Ganesh. So the glutamine is replaced by the valine and as a result there is HBS formation. Okay, so tell me, what is the mutation? What is the mutation over here in sickle cell anemia? What is the mutation? What is the mutation? So here they have told nonsense mutation. So that is wrong. What is the mutation? It is a point mutation. Okay, it is a point mutation. Okay, and it is in the 6th position of the beta globin chain. Okay, remember it is a point mutation. Point mutation. Okay, yes, Tej is right. It is a point mutation. Fine. Next, sickle trait patient do not have manifestation as that of sickle cell disease because 50% hemoglobin S is required for occurrence of sickling. Okay, or HbA prevents sickling, or HbA is less than 50% and HbA has low affinity for HbS, or HbA prevents the polymerization of HbS. Give me the best possible answer here. Okay, no, the answer is HbA prevents sickling. Okay, so HbA prevents the sickling. Sorry, one second. So HbS is less. One second. HbS is less than 50%. HbA has a low affinity for HbS. So that is the answer. Okay, 50%. So generally HbS in the trait is between 30 to 40%. But the main thing is the HbA has low affinity for HbS. Okay, so that is the reason. Fine. So HbS is less than 50%. So if this part was not given, if the HbA has low affinity for HbS, then I think you could have given or put the option of 50% of HbS is required for occurrence of sickling. But since the HbA has low affinity for HbS is there, so that is why HbS is less than 50% and HbA has low affinity for HbS is the answer. So HbF doesn't prevent sickling. So basically HbF is there, no? It only helps in the oxygenation part in the body. Okay, oxygenation part. So only if this HbA has low affinity for HbS was not given, then you could have gone for the 50% of HbS is required for occurrence of sickling. So you have to read the entire question properly. Okay, so that is the main thing. And what was your question? HbF. Yeah, HbF. The fetal hemoglobin is very important for the oxygen carrying capacity in the body. Okay, that is because HbA is not there. So when HbA is, even in thalassemia, why is HbF persisting? Because we need the oxygen. So slowly as the child progresses, this HbF will slowly come down. So in cases of thalassemia and in sickle cell anemia, HbF doesn't disappear like a normal child. So in these conditions, the HbF takes a longer time. There is a delayed disappearance of HbF. Okay, so that you have to keep in mind. Next, which of the following is not seen in chronic case of sickle cell anemia? Hepatomegaly, pulmonary hypertension, cardiomegaly, or splenomegaly? Yes, the answer is splenomegaly. So basically, in a chronic case of sickle cell anemia, there will be autosplenectomy. Okay, so that is why splenomegaly is the answer here. Fine. Commonest acute presentation of sickle cell anemia. What is the commonest acute presentation? Is it priapism? Is it bone pain? Is it fever? Or is it splenomegaly? Commonest acute presentation. All these are present. Oh no, not all. Okay, tell me what is the commonest acute presentation of sickle cell anemia? Yes, so correct, Aparna. The answer is bone pain. Okay, so one of the most common presentation is bone pain in these children. Yes, all are right. Okay, priapism again is common but not as common as bone pain. Fine, very good. Next, all of the following are true about sickle cell disease except they require repeated transfusions. Acute infection is the most common cause of mortality before 3 years of age. There is positive correlation between the concentration of HbS and the polymerization of hemoglobin S and patient presence early in life before 6 months of age. So which of this is not true? Not true. Read it aram, say slowly or read it and then come to the diagnosis. Yes, Aparna, right. So here the patient presenting early is not. So generally they present after 1 year. Okay, so after 1 year of age. So the answer is patient presenting early in life before 6 months of age is wrong. Okay, so they generally take more than 1 year to present. Fine. Next. All of the following are true about sickle cell disease except mutation in the alpha chain, symptoms are ameliorated by HbF, veno-occlusive crisis is the cause of mortality, and bone pain is presenting feature. What is false? Yes, very good. So this is a very simple question. So the mutation is in the beta chain. So right, right. Okay, so next question. Which is not seen in hemoglobin electrophoresis in sickle cell anemia? Is it HbA, HbA2, HbF or HbS? So what is not seen? Yes, so the answer is HbA, correct. Okay, so the answer is HbA. So HbF, HbA2 and HbS is seen. So the answer is HbA. Fine. Now, crew haircut appearance in the X-ray skull and the Gandhi gamma bodies are seen in J6PD deficiency, Hodgkin's lymphoma, hereditary spherocytosis, or sickle cell anemia. So crew cut and the Gandhi gamma bodies are seen in which condition? So you all know about it. Yes. So the answer is sickle cell anemia. Okay. So tell me why. What is gamma Gandhi? What does indicate gamma Gandhi bodies? So Gandhi gamma bodies indicate what? What does it indicate? So they will indicate congestive splenomegaly. Okay. So in congestive splenomegaly, that is seen. Okay. So also in conditions like portal hypertension, also Gandhi gamma bodies seen. So tell me, Havel Jolly bodies indicate what? Havel Jolly bodies indicate what? What does Havel Jolly body indicate? So Gandhi gamma bodies indicates congestive splenomegaly. Okay, also they are present in sickle cell anemia. So Havel Jolly body. So first of all, first there is congestion only, right? Eventually it goes into asplenia and sickle cell anemia. So when Havel Jolly bodies indicates what? You all know the answer. Yes. So it indicates asplenia. Okay, so it indicates asplenia. Remember, Havel Jolly bodies indicates asplenia. Gandhi gamma bodies are seen in sickle cell. So both Havel Jolly bodies and Gandhi gamma bodies are seen in sickle cell anemia, but in the different phases. So in the initial phase, where the spleen will be sequestration of spleen which is happening, there is a congestion in the spleen. So that is Gandhi gamma bodies. Eventually, there is splenectomy. After splenectomy, that time Havel Jolly bodies are seen. Okay, so remember Gandhi gamma bodies and Havel Jolly bodies. Fine. All are true for sickle cell anemia except pulmonary artery hypertension, fish mouth vertebra, leukopenia, and increased size of the heart. So what is not seen? Yes, post splenectomy. Teachers, you got bored, huh? So I had told for 2 hours first only. So anymore on 15-20 minutes it's there. So I have sickle cell anemia few questions and then a few questions on thalassemia and done. Okay. Hmm. Okay, so the answer is leukopenia. Fine, good. So fish mouth vertebra, pulmonary hypertension, and increased size of the heart is seen. So leukopenia is not seen. Correct. Very good. Okay. So sickle cell trait is protective against which infection? So by 20 minutes I'll be done. Okay. Tell me. Sickle cell anemia, sickle cell trait is gives protection against which infection? Hepatitis B, Salmonella, Staphylococcus, or Plasmodium? You didn't have lunch stages? Okay, so Plasmodium. Fine. So another thing I want to tell you, ask you, if there is sickle cell anemia and you suspect a salmonella infection in a sickle cell anemia patient, okay. So this patient who has sickle cell anemia with salmonella infection, what is the high chance of developing? What infection can they develop? Which part of the body? Which infection can they develop? Salmonella and sickle cell anemia. Salmonella infection in a sickle cell anemia patient, what can they develop? Over in 20 minutes, I'll finish it fast. Okay, so in patients with sickle cell anemia and if they have salmonella infections, you have to think about osteomyelitis. Osteomyelitis. Okay, you have to think about osteomyelitis. Okay, tell me what is the feature of the osteo? Yeah, very good, Aparna. What is the feature of osteomyelitis in these patients? So generally a normal osteomyelitis, it is common in the metaphysis, but the sickle cell anemia osteomyelitis, it is common in the diaphysis. Okay, so remember that the osteomyelitis in sickle cell anemia affects the diaphysis, while the osteomyelitis in the normal infective osteomyelitis infects the metaphysis. Fine. Next. Okay, so the most common mutation in beta thalassemia involves, so a few questions, 5-6 questions done then. Okay. The most common mutation in beta thalassemia involves, is it intron 1, intron 22, 619 BP deletion, or is it 3.7 BP deletion, that is base pair deletion? So tell me which is the most common mutation in the beta thalassemia. So this is the last chapter. So tell me, what is the most common mutation in beta thalassemia? No, the answer is intron 1. Okay, intron 1. Intron 1. Intron 1 is the most common. Fine. If you have any other answers where if you're specific, if you think it is 619, if you have any literature where it tells it is 619 BP deletion, let me know. Okay, but the answer is intron 1. If you have any other literature which tells it is 619 BP deletion, let me know. I will correct it. Okay. Now, all of the following are true for beta thalassemia except microcytic hypochromic anemia, increased HbA2, increased HbF, or platelet patient requires blood transfusion. Oh, so once again, this question was trait. All of the following are true about beta thalassemia trait except beta thalassemia trait except trait. Okay. All of the following are true about beta thalassemia trait except trait. You're talking about trait. Okay, so in the trait, the patient doesn't require blood transfusion. So the answer is blood transfusion. Okay, so there is microcytic hypochromic anemia in a beta thalassemia trait. There is HbA2 will be the increase. Okay, HbF will be increased. Then these patients do not require blood transfusion. That is a very important thing. Okay, so thalassemia. Yeah, trait. So I made, sorry, I didn't write this thing. This thalassemia trait, and thalassemia trait requirement of blood transfusion is not there. So HbA to HbF is increased, HbA is decreased. Okay, so the answer is the patient does not require blood transfusion. Okay, fine. HbH. What is HbH? HbH is characterized by HBH is characterized by deletion of 3 alpha chain genes, deletion of 3 alpha chain genes and 1 beta chain, deletion of 2 alpha and 2 beta chain, or deletion of 4 alpha chain. So what is HBH? Very few questions, we are done, okay? Yeah, very good, Ganesh. So the answer is deletion of 3 alpha chains, okay? So deletion of 3 alpha chains is called as HBH. Fine. Diagnosis of beta thalassemia is best established by, is it Nestrov test, HbA1c estimation, HbA electrophoresis, or target cells on peripheral smear. So which is the best test for beta thalassemia? Hmm? So the best test, tell me that what is the best test? Yes, it is HB electrophoresis. Okay, so the best test for the diagnosis of beta thalassemia is HB electrophoresis. Okay, fine, we are done. We are done. Yes, all are right. So we are done. It was a long test. I knew it was going to become exhausting at the end. Still, there are so many topics to complete. So that is why we will do. So I've decided in the next week, every alternate week, I'm going to keep quiz. Okay, I'm going to keep MCQ discussions every alternate weeks before starting the topic. Okay, so that we can finish all the past questions before the next week. Okay. Yeah, so tomorrow I'll be starting approach to bleeding, bleeding disorders. So before that, I will talk about the marrows, basically hypoplastic. Uh, yeah, thank you. Yeah, so we'll do all the marrow discussion. So hypoplastic, and normal cellular. What are the causes? So before starting approach to bleeding disorder. So once that is done, from Monday, I'll keep every alternate days. I'll start with at least 15-20 questions and then discuss the normal topic because there are so many questions. Okay. Yeah, fine. So good luck, study well. So I know it became too long. So anymore, I won't keep a 2-hour class. Maximum 1.5 hours. I know you get hungry also. So we'll do 1.5 hours class maximum. Okay. So study. Okay. Eat well. Do not skip your meals. If you don't eat healthy again, your health will get affected. Eat healthy, not oily and all that. So eat healthy food. Take care of yourself. And if you have a study partner, discuss with them. This will help you to remember better. Okay, fine. So good luck, study well. And if you're subscribing to the subscription, use my code Shilpa10 and get a 10% discount. So all the best. Yeah, thanks Ganesh, Tejas. Thank you Aparna. Okay, so for attending the class. Tomorrow I'm not having any quiz. Tomorrow it's going to be and then Aparna had asked me a question about paladin. So paladin is a part of the cytoskeletal system which will help in the proteins. So though it is not a protein as such for hereditary spherocytosis, it is required for those proteins to maintain the cytoskeletal of the RBC. Okay, so that is why paladin is not paladin is a part of hereditary spherocytosis, but it is not the main protein. Okay, Aparna. So that I wanted to discuss. I missed the question that time. Okay, so paladin is not a main protein in the pathology of hereditary spherocytosis, but it is required to maintain the cytoskeletal structure of the RBCs. Okay, so it is not the main, but glycophorin, though it is not at all associated. So that is why that was the answer. Okay, fine. So good luck, study well, stay safe. Bye. See you.